thanks everybody for taking the time out to kind of go over stuff, and hopefully this just serves as a preface for considering knee replacements. There's some advancements here locally and the way we approach these things as far as doing knee replacements. That I'm trying to make forth a little bit of education on that and what our opportunities are to really hopefully change the face of this in the future. This is really reflecting that. It is a pretty limited presentation, not to bore anybody that is watching, but hopefully just to at least spark some questions so we can go from there. All right, thank you. So once again, this is focusing on knee replacement as an evolution of a process, something I've coined as far as a next knee, which is kind of next generation, and utilizing some of the advancements and moving forward with knee replacement. I'm John David Burrow. I'm an adult recon specialist, which means I specifically focus on joint replacement. Work here at Orthopaedic and Spine Center in Newport News. Let's see here. All right. So really, as far as knee replacements and trying to devise something that may be a little bit better in approach, is really a push for myself because I see the need for better. There's been an evolution of replacements, mostly with hips, and an evolution of approaches and seemingly better outcomes, especially in the short term, much better improvement of pain post-surgically as well. And as the forefront of pushing towards outpatient surgery and doing these essentially as elective cases in such manner, then we need to be a little bit more prepared in being able to progress people to that level. And so this is an idea, of trying to streamline these, improvements, and noting that with some changes in the way you address the hip or the knee implants, as well as the changes in approach and as well as our therapy, hopefully we can get a better outcome at the end and a quicker return to function. So again, hip arthroplasty has really seen that evolution over the past 10 years, maybe a little longer, to where the change in approach has really improved initial outcomes. I remember even when I was in training, which was about 10 years ago, that the typical hospital stay for a total hip replacement was close to 3 to 4 days. And now we're doing it as outpatient. Actually, I had surgery today and 3 people went outpatient. So it is completely revolutionized how we address these things, and obviously for the patient as well. So the initial outcomes have markedly improved in the first couple of weeks, especially in the reduction of pain and increased mobility and return to function is the biggest things that we see. After about 4 weeks to 6 weeks, no matter what approach, hips generally do well. But 4 to 6 weeks of your time, and as well as the initial investment into the process, is quite a savior if we're looking at trying to cut these times back. So we reflect back to essentially the history of knee arthroplasty, and it's relatively a short history to the conventional knee that we are using now. This is the initial process. This is the initial implants from 1974 from Hospital Special Surgery, and Dr. Ranawat was the one who was the head in the panel for developing this in the first implantation, and really most of its variations have modified from this base. So it really hasn't changed a whole lot until I would say about the last 10 to 15 years, and where we started looking at kinematics and the way that the knee joint actually works and how much difference that makes for how a knee actually does as far as a replacement. So initially an attempt at doing a knee replacement in 1864 in England with essentially ivory that was honed into like a hinged prosthesis. Failed miserably, but it was an attempt. And then not much was heard of it until about 1968. Again, in England, there were some attempts at condylar replacement, singular, but not a total knee where all components of the knee was addressed at one time. not until 1974. So Dr. Ranawat, as I was speaking about, did develop that and move forward, and really has brought us to where we are today. So it continues to be an evolution. There's multiple companies and multiple designs. All of them really function on the same basis and principle, for the exception of few and some relatively more advanced techniques. There's patient-specific designs, which is actually one-off custom implants that's designed for patients. Again, looking for that need to try to improve better function and outcomes. They offer some advantages, and I feel like they offer some disadvantages as well, but that is a possibility. Robotic Assistance is another development that over time, as we try to pursue this so-called perfect knee, some additional possibilities to improve balancing and function is also a big push in recent years, and maybe the possible future of replacement as we're able to determine those things. And then kinematic designs, which means that it's just trying to understand the actual anatomy and function of the knee, the dynamics of the knee, and then trying to replicate that with the designs of the components, which has also been a big push in recent years as well. And all three of these actually do seem to improve function of the knee and give you more of a normal feeling knee after knee replacement. So obviously knee arthritis, everybody kind of knows the symptoms, crick and snap and pop and all the other noises that goes along with it, but what is actually causing that? So I think we have to understand the basis of what knee pain is from arthritis as we kind of move along through the talk. So essentially on x-ray, when we pull up x-rays and say you have arthritis, what we're looking at is a comparison, typically in our head, of a normal joint space, which you see on your left, and then a arthritic joint, which is severely arthritic, on the right. And essentially it's loss of that clear space that the arrows are pointing at. And that's the cartilage level. That's essentially, like I like to say in office, tread on the tire. And if the tread is there, then you're good to go. And if it wears down, then the symptoms become pain. And also loss of motion and function and all the other things that kind of goes along with the process of arthritis. But it is important to understand that it is a process. This is not something that happens overnight. This is not something that changes with an injury. Most of the time people come in with an injury to a knee. We get an x-ray and we'll say, well, you've got some arthritis. Well, they don't understand that the arthritis was pre-existing the injury. The injury may have shifted and increased their pain, but the underlying process has been ongoing for quite some time. So as it is a progression, we look at the progression of disease. And stage one is fairly focal, as you see all the way to the left. There's the image really doesn't completely project very well, but you can see that there's maybe some small areas, a small little lesions here on the cartilage. This is kind of like a little pothole in the road. And as the road wears with time, you get a few more potholes. And then as the potholes grow larger, they encompass large areas. And that's kind of the idea of the progression of disease. And at the end stage down here at 4, essentially you're on a gravel road at that point. And that's where all your sounds come from, your snapping, clicking, and popping. So understanding the anatomy of the knee is a big part of this as well. And we talk about a number of different things. The meniscus seems to be a big focus for a lot of people, as it is a very typical and common injury. And I'd say it's kind of a precursor for a lot of the things in the future because the meniscus works as a gasket to kind of guide the motion. So a lot of times the injury to the meniscus kind of precludes or development of arthritis in the future because it changes some of the dynamics of the knee, and then additional stress happens to the cartilage. This is the cartilage here, and it is a very glistening white cap to the bone, and essentially is the gliding surface in which the knee functions on, and that's the bearing, if you will, inside the knee joint. And then we have some ligaments. This is the ACL. Tucked back behind it is the PCL. Those are some ligaments that stabilize the knee with front to back slide motion. This is a collateral ligament, the lateral one. There's also one on the inside part of the knee, the medial collateral. And these are the stabilizers of the knee for all intents and purposes for overall stability of the knee and side to side motion. And then the kneecap here sets in front and works as a fulcrum point to gain the strength to be able to extend the leg out But for this muscle to do its job, it needs a resting point. So that's the function of the kneecap as a fulcrum or a pulley. So again, understanding the dynamics of the knee and why that is a lot more involved process as far as total knee replacements, even considering total hip replacements. The difference there is that there's much more dynamic motion that's responsible at the knee. Essentially, it's two somewhat flat planes that kind of articulate against each other. And so if you take a marble on a plate and then roll it around, you know how difficult it is to stabilize it and keep it in one place. So we rely a lot on the structure of the joint, the shape of the joint, as well as the ligaments that are inside the joint to try to maintain that stability of the knee and give a functioning knee. So essentially 6 degrees of motion is what we look at. It's what we preach about as far as joint replacement surgeons go. And extension and flexion essentially is 2 motions. Varus valgus, which means that the knee will tilt side to side, in or out. Anterior posterior, meaning that it will shift front to back. And then rotation, and also side bending, meaning that it will rotate on a platform or a pivot about the center axis of the knee. So in typical, and even starting back to 1974, knee designs were focused on essentially a fulcrum or a point of axis. Centering that point of axis and the rotation of the posterior aspect of the condyles on the knee itself was thought to be the best way to approach the overall motion. And it is a functional approach to the motion. However, the recent pushes in trying to find a better answer, and the kinematic designs kind of leave this idea somewhat and try to introduce some of the other more normal patterns of function to try to improve the functionality of the knee. So essentially we're looking at normal knee and then what we're calling measurements or calibration. So a more typical and approach for knee replacement, essentially squaring off a box within the joint space, cutting off enough bone to give us this gap to fill to make the knee essentially work like a hinge. And then the kinematic idea is that, well, not everybody's knee and balance and the alignment of their leg is the same. So if we modify these bone cuts, what tolerances can we get to try to improve the function of the knee that best matches the person itself? All right, if you have any questions, click on the Q&A button on the screen and type it in, and we can discuss it as we go along. All right, so again, revisiting that anatomy as we talk about the condyles, this being the lateral and the medial condyle, are shaped relatively different, okay? The A to P distance of the lateral condyle is increased than the medial aspect. The medial is more medial to lateral or wider than it is tall. And so the functions of that as a difference is the way the knee functions oftentimes works as a pivot or kind of a fixed rotating motion on the inside part of the knee and more of a slide mechanism on the outside part of the knee to where it can rotate and do its function. Again, visiting these degrees of motion, really this last option here where we're talking about rotation is a big part of this that is not easily fixed with more traditional bearing sets and knee replacements. And so that has been the push and really the focus of knee replacements for several years as the evolution of design has gone on. So again, looking at the axis and or what we call the axis and the alignment of a limb. So trying to focus on, correcting a deformity. Most people in the x-rays or this diagram doesn't really represent the arthritis that would be in the joint. So you'd expect to see a tremendous amount of loss of space on the inside part of the joints on this picture to the left. And as these options show here, it's just different presentations of a way to approach a knee replacement patient-specific, meaning essentially you kind of accept the deformities. You may be able to correct it somewhat, but essentially you're just kind of resurfacing the surface that's there and then keeping the alignment that was given because that's what the body's used to. Well, the body may not have always been used to that, and it may have progressed over time. So just resurfacing what's there without making a significant change can lead to some other problems, including excessive wear, loosening over time, or really a function that is subpar for our expectations. Another possibility is kind of a combination or a hybrid of such, in which the knee replacements are designed in somewhat correlate to the patient-specific design and needs, but we also are able to realign this axis, the hip center, through the joint and down to the center portion of the ankle, which is very important for the function of the knee over time. And then the last one here is maintaining a center axis through the hip, through the knee, and the ankle. Thought to be the best option, but there is some concerns that may not lead to a overall best outcome for each individual person. So the more modified approach to where we're addressing patient-specific issues as this hybrid approach, I think may be one of the better answers. So we have a couple of questions kind of going back to some of the questions that mostly about the meniscus, as we were talking about before, which is very common. I just pushed the answer live there. Can I talk about it? All right. So Deborah asked, do all meniscal tears need surgery? Yes and no. There certainly is a subset of patients that are symptomatic. And those that are symptomatic often do need surgery. If we were to line up a bunch of people, take MRIs of their knees, then we would probably see that probably 30% of people actually have a meniscal tear that's not symptomatic. So really we address it as a symptom. And oftentimes when they become symptomatic, they are large enough that they're engaging the joint surface. And as that engages the joint surface, it takes up space. It can propagate or tear larger, or it can actually start causing problems with the cartilage itself, damaging that cartilage, which we talked about can be a progression of arthritis over time. So do all meniscal tears need surgery? No, because a lot of them are asymptomatic, but those that are symptomatic are typically large enough to cause problems and typically do. Let's see what we do here. All right, and so another question comes from, can stem cells heal a torn meniscus? There's some question about that, some debate about that. It certainly shows that there may be some proof to some healing potential of that and even some regeneration of cartilage. But again, the severity of the injury is a big part of what determines how well things do, even with stem cells. Obviously, the more conservative we are with our treatment options, the outcomes we expect to be a bit more conservative as well. So if we are dealing with a meniscal tear that is large, like a bucket handle tear, which essentially is a big flap tear and the whole meniscus is displaced, then no, a stem cell injection probably won't do much for that. If we're talking about a small undersurface tear, kind of in the peripheral edge of the attachment to the capsule and the soft tissues of the joint, without significant displacement, then yes, it is a possibility that a stem cell injection could help out. Need some help with getting this back here. I don't know what I did. All right. All right, so thank you for your questions, and certainly we will continue with additional questions as we move on. So as we were talking about the kind of the hybrid technique of surgical replacement for knee replacements, I use a combination of imaging, an MRI that essentially is calculating the joint and the surface that we needed to consider reconstructing, which goes along with another film that I'll show you in just a second. But even here, you can see that on an MRI, it's pretty plain that we can see damage to the surface, the loss of the cartilage, which is this kind of soft gray halo that we see through here on the outside part of the joint that essentially is missing on the inside part of the joint. And so that represents, the arthritic change over time. And so the MRI serves as a roadmap for us to be able to determine integrity of the ligaments, the soft tissues that we will have to address to balance, and the overall idea of moving forward with a knee replacement that will be best fit for the situation. So these x-rays are then compared with the MRI, and essentially these are the long leg x-rays. The long leg x-rays try to find that axis of balance that we were showing from the previous x-rays, our previous slide. And so the idea is to try to get a more normal kinematic flow or function of the knee, trying to get the hip center back at least to the ankle. The knee can be a little bit of a variation in between because everybody has a little bit different alignment there. All right, so what I utilize is something called patient-specific cutting jigs, and essentially it's utilizing that information. We're calculating the differences and the tack, essentially, of how we're going to make the bone cuts to make the component work best for what we're trying to do. Essentially balance the knee and regain that function with that kinematic access or that kinematic idea in mind. All right, we have a couple of more questions. Robert says a pretty specific question about his knee being painful, having a grinding sound, and he can't put any weight on it. He saw a military doctor, did an x-ray, and shows that he doesn't have any cartilage. So that's pretty consistent with the underlying arthritic change. And again, a weight-bearing pain or even something as far as an injury that had increased some pain certainly is kind of the first presentation or the symptoms that we'll see. And then he's been getting corticosteroid injections for several years, but they have reached the point where they're not doing any good. So essentially, as that initial chart, or one of the initial charts we looked at, is the progression of the disease over time from 1 to 2 to 2 to 3 and 3 to 4, now progressing from that 3 to 4 level, and it's not uncommon that the arthritic change is just severe enough that the symptoms continue even with the treatment plans, the non-surgical aspect of that. So oftentimes that is where you're looking at moving forward with knee replacements, because our options are pretty limited beyond the injections, which I anticipate to be one of the better treatment options to kind of preserve function to the point where it doesn't work. Rich says, I'm experiencing intermittent pain in my left hip, radiates down in my groin area. Do stretch muscles and ligaments and workouts and haven't found any relief. Golfer, it's difficult to swing or shift his weight. Does it sound like ligament damage, bone, or joint integrity? I will tell you, groin pain that's persistent, even with stretches and such things, often times point to arthritic changes of the hip. It's difficult to see and obviously diagnose these things just off of presentation of symptoms, but typically we start with x-rays, look at it, and then decide what is going on from there. Certainly there could be ligament strains and other issues within the joint that wouldn't show up on x-ray, but typically the x-ray is going to be our basis for diagnosis and moving forward at that point. All right, Mr. David says, if knee replacement is not indicated yet after a first ever significant inflammatory attack in one knee, how should I manage my condition over the next decade? or what period am I still reasonably functional? That's a good question, and everybody has a different timeline. It really depends on the severity of the disease and really the pain and tolerance level, as well as the activity level. Everybody is different in that regard. So really, for me, the limits of motion, the limits of function are something that I typically, start becoming concerned with from my standpoint, because that's the more difficult things to try to reconstruct when we're talking about knee replacement. But as far as pain goes and limitations of activity, it's really determined by the patient themselves. Depending on a number of factors, and determining whether or not you're a candidate or whether it's indicated, I think is a bit variable, and everybody has their opinion there. But there are a number of factors that should be reviewed, and there may be some other possibilities, different types of injections, stem cells, something called PRP or platelet-rich plasma, injections, which is the corticosteroids, which work well for usually a significant amount of time. Obviously, the medications, anti-inflammatory medications, which can be taken for a long period of time, and other injections like viscosupplementation, which are done in a series, which have pretty good outcomes as well. All right, so we move along. So again, with a patient-specific design, again, trying to find that normal kinematic axis and relative function of the knee. So these are essentially fabbed for the patient, utilizing the MRI and the long leg x-rays to kind of calculate off the basis and the idea of trying to correct that axis to improve the function of the knee once we insert a knee replacement. So again, when we're talking about a knee replacement, it's not we're just lopping off the ends of the bone and just matching it up. It's actually pretty precise, and to where we're only taking a few millimeters of bone off the edges of the joint all the way around. And the amount of bone and the position of the bone and the angles that we cut are oftentimes what is responsible by the function of the knee and what may be limits of motion. It could be too loose if we cut too much. It could be too tight if we don't cut enough, or it could be loose in one direction and tight in another if it's not balanced in these cuts. So this is a big part of the art that goes into the knee replacement. So again, looking at the kind of the functional design and trying to replicate some of that rollback, as we call it, shift. The inside part of the knee works more as a pivot. As you can see, the small blue circle is kind of a pivot point, and then it does shift back and engage this back surface. The lateral position, or the lateral portion of the joint, slides around this medial portion as a pivot. So if you anticipate that the anterior posterior portion of this, the front to back motion of this, as it slides, is more relatively significant to the more fixed bearing portion or the fixed pivot point of the inside part of the joint. With more traditional knee implants, essentially it replicates this fixed bearing here and here. So we lose some of this slide motion, which is really functional for rotation and flexion, and really the normal motion of the knee as we do activity, which I believe leads to some people's concerns and really ongoing pain, which represents probably about 20% of people have knee replacements have some persistent pain of sorts. And I think it's probably because we've lost this kind of normal idea of what function should be, and that loss of function is presented as pain. So again, this projects very poorly, but I'll give you the general gist of this. Is the idea that certain implants, as they have studied, has a point, a load point in the motion. And essentially, the particular implant that I use actually allows for a bit of this slide, as these are kind of fixed points of contact and motion and flexion. This allows this point contact medially and this lateral slide on the outside portion. So I think that does make a difference, and it's one of the reasons I use a particular implant that I use. So this is actually a picture of the implants, a small change in some of the elements and the increased portion of the rollback portion of this, so it allows for more surface coverage for a deeper bend and deeper flexion. It's a longer J curve here, which allows for more of a pivot and a shift, versus being essentially circular, which allows to be more of an anchored point. So we have that information. We have an idea of how we can make the knee joint work better, but what can I do to get it in place and make that portion of the puzzle improved as well? So the major workhorse for many years has been an approach to the knee we call the medial parapatellar. And essentially what that is an incision that goes through the quads tendon on this outside edge around the kneecap and then down along the patella tendon to the anchoring portion of the bone. And then we get access to the knee of that like a doorway. It is a literal workhorse. There's many advantages. Most of it is that it is familiar to most. It has excellent exposure. Even in challenging cases, you can get a lot more exposure to the joint. But there are some fair disadvantages. Obviously, repair of that can fail. The tendons are very thick, but sometimes they can be compromised, and repair of that access can lead into issues with the tracking of the kneecap, as it's very dependent on these structures to maintain the center position of the kneecap. It can sublux or shift to the outside part of the knee. You can have a little less direct access to some parts of the knee, but overall it's a fairly well exposure. But the other things that can be affected that's really not talked about here is what functions these apparatuses do. Within our tendons, we have a number of complexes and something called Golgi complexes. And essentially it's a tensionometer. And essentially it gauges how much tension's on the joint, how much tension's on the ligaments, and will shut down function if it feels that it's in a fair or reasonable range of failure, meaning that it may rupture if it gets stressed too much. So obviously, as we cut these things, we are repairing, and these same apparatuses are affected. And that may be a fair amount of the difference from person to person, but also why we see that this approach may prolong the healing recovery process a bit longer, and some individuals more than others, but may be a reason for the differences, which may be reasonable to utilize a different approach if you can. So as a modification of these things and moving forward, we review the overall surgical exposures to get in the knee. D is a lateral approach, which is utilized for me mostly for focusing on just a partial replacement where we do just a portion of the joint and outside part. But for this purpose of this talk, we're talking about total replacements. A, again, the workhorse. B is a modification of the workhorse, which has really been somewhat the gold standard for many years, where there's this little, what we call a vastus snip. The approach is much the same, the exposure is much the same, and the portion of the muscles affected to try to get some additional exposure. It works pretty well. There's much less concerns for the initial pain and stiffness, and the overall functioning of the joint seems to return fairly quickly as we leave the tendon mechanism relatively alone. And then there's modifications of that, the subvastus approach, which is not a new approach by no means, but has been visited and left multiple times because of concerns and really the limits of their approach itself and difficulty gaining access. And now, less arthritic knees, you can have a much easier access, but I would challenge that if it's that easy, because there's not as much arthritis and much things that you have to balance, then you may not need a knee replacement at that point anyways. So some level of in between B and C is kind of the evolution and modification of the exposure at this point for what I'm doing. This I see to be the most advantageous to gain access, do the corrections we need to do, as well as leave these tendon complexes alone that really quickens the recovery process and the post-surgical pain. So moving forward, as far as the next knee, the general idea and the concepts of this is the combination and evolution of these techniques. It is as simple as trying to develop the best implant choice for the patient, identifying the surgical approach that's going to work the best, and then instilling proper rehab protocols to make sure that what we do is going to function the way we want it to as the patient go on to heal. Motion, strength, and stiffness is all a function of the appropriate rehab post-operatively. Now, if we can improve those functions, essentially by early mobilization, meaning you get up and get walking faster, then obviously the rehab function of this becomes a lot less daunting. And as improved function continues with these factors taken into place, as your total time frame is, I would initially say, in a more traditional approach to knee replacements, and really what I was doing over a year ago would be limits of motion would be fairly persistent for 6 to 8 weeks, and I've seen that time frame essentially cut in half, and even less than half, which is a drastic improvement for the patients. But not only that, by not involving these tendon complexes in this feedback loop, which our body's responsive to pain. Pain tells us when to stop. So the feedback loop for these Golgi complexes, anticipate, is a big factor of what generates some additional limits of our motion initially, as well as the significant amount of pain. The muscle doesn't have as much of that, so as we have to maybe extend an approach a little bit, affecting the muscle more than the tendon, typically, much like a pulled muscle, it's going to be sore for a few days, but life goes on. It's manageable. A tendon, a torn tendon, or a torn ligament is a much longer process, and even with ankle sprains and such, we will see swelling and limits of motion and all the things that we know from a general orthopedic standpoint that take 6 to 8 weeks for it to heal, which kind of goes along with the principles of the knee and motion and limits of motion, which may take 6 to 8 weeks as previous. So essentially, if we're able to improve that function in the first 2 weeks, the surgical standpoint and the time from surgery, we're able to increase our function, we're able to increase our mobility, and essentially decrease the pain, which obviously makes it a little bit more palatable to undergo a big surgery like this, because I oftentimes tell people this is probably one of the more painful surgeries that we do as a orthopedic surgeon, but this is quickly making a difference in that standpoint from the way I see it. And the overall idea of these principles combined is to get a more natural feeling, more natural acting knee at a 1-year standpoint, which sometimes it can take that long, but I see that that's also changing as well, and maybe more of a 4 to 6 month standpoint. And so this is an example of a patient that underwent these principles, the same techniques and design of the implants, as well as the exposure. Here we go here. Keep sweeping it. And play this video for you. He is 10 days post-operative, coming into the office, carrying his cane, I guess, to ward off the dogs outside, but obviously not needing it. Minimal swelling, minimal pain. Doing very well at 10 days. And he's not the only one that I've seen. He's kind of what I expect to see at that first post-op visit at this point, as this really has changed the way that I practice and the way that I approach knee replacements. All right. So thank you. If there's any additional questions, certainly you can let us know now. Additionally, obviously, and hopefully, this raises a bunch more questions about knee replacements, the opportunities for knee replacement, and the idea that hopefully we are modifying knee replacements to a point where it is less concerning, but everybody is different. Everybody is specific to their disease and the disease process as far as arthritis goes. And so your answers may be different individually. So additionally, I would recommend obviously an evaluation or appointment to kind of review these things as well. Thank you.